We're right now in Melbourne, Australia at the 20th International AIDS Conference. And one of the traditions that ICAP has had over the past several years is to host pre-conference meetings that have focused on very specific timely issues of interest in the field. And this is the fifth such meeting that we have sponsored. And the last ones have been focused on issues like health system strengthening, issues around the integration of HIV, care, and non-communicable disease. And this conference today, we're focusing on quality and quality improvement. Well, we're very thrilled that we have at this meeting people coming from 28 countries around the world. What's interesting is not just the countries where they come from, but also the mix of expertise and the diversity of disciplines. So we have people who are policymakers, we have those who are program implementers, we have people who are frontline providers, as well as we have also researchers in the room, as well as community representatives, people who represent communities of people affected by HIV. And we're hoping that by bringing the mix of people and the mix of expertise that this will generate momentum to try to define the path forward, the trajectory towards achieving quality programs.
One of the reasons we're meeting today is because quality is really become kind of a buzzword in our programs, and it means a lot of different things to a lot of people. So I think today was a great opportunity to explore some of those definitions of quality.
Many people know about quality assurance, but they don't have a clear picture of what quality improvement is and how these two are different, or how these two could complement each other. So the first thing is to convince people, to convince policymakers, and to convince the people that are working, the service providers themselves that are working on the ground, what quality improvement is.
QI is just ensuring that you do what you have to do, but do it well and continue to improve using innovative approaches or innovative strategies.
We know the interventions that work, but are we delivering these interventions in a way that makes them optimal to have the desired impact that we need? And where I think we need to focus is to define simple methodologies for delivering these services, but also monitoring these services so that we have a feedback loop to what we're trying to do in the system.
Quality improvement is basically the black box between implementation and success. So it's about making care better, and it's about giving the right care to the right person at the right time every time.
It motivates them, the health workers, at the service delivery point. We always think that motivation is about money, but from my experience, I've seen nurses who are so motivated. They've instituted some changes and they have improved, and they just celebrate that shift from 80% to 85% of whatever target that they had set for themselves.
There are a number of challenges in quality, and this conference has addressed some of them very properly. One is moving from the coverage to the outcomes and the impact. We have been so much looking at the coverage in terms of numbers, bringing in a bigger number of people to start ART and get enrolled, but then looking at where do they end up has been a challenge.
We have tremendous achievements in PEPFAR, particularly supported programs, working in partnership with host governments to actually start turning the epidemic around. But what we're identifying are huge gaps along the continuum of care. And we're discovering that continuum of care is very different for different populations.
We know that there are still substantial proportions of people living with HIV who don't know their status and who are not linked into care. So that is a critical one, that we have to do a better job at creating, implementing, developing testing programs that are attractive to people, that actually fit with people's lives.
There's many gaps in around understanding how do we keep people in care at this pre-ART time between testing and linking into ART. And I still think we don't have a lot of information about about models of implementation at that period of time to keep people in care over the long time.
The second critical area, it seems to me, is the problem of people who have been initiated on therapy but who are no longer on therapy. And they may account for as many as a third of new infections. And it's critically important, I think, that we cease to think about starting people on therapy as the measure that we're using, but rather really look, and this is where quality improvement is so key, at the proportion of people who are successfully virally suppressed.
I think the direct engagement of communities really does two things. One, it addresses stigma and discrimination because it makes people supportive of one another, whether they have HIV or not, but it creates a community around the HIV positive patient where there's no longer this sense that they are separate from, but part of a community. And I think that's so important in receiving care and long-term care, is to feel like you have a support system that's broader than yourself.
So it is very important when you engage the community to understand what their needs are, what they should be expecting from the care provider, and then these two can then communicate, and then we have better quality care.
One of the best ways to do that is to actually talk to the patients, involve the patients in the care that they need. We would either ask them through interviews or questionnaires or others, and probably the best way is to identify, in addition to the surveys and interviews, to identify a patient or two and to invite them to be a member of the improvement team. When a patient sits on an improvement team and gives their opinion and starts to weigh in on the redesign and the changes that we're making to make sure that they're being focused on their needs, we're going to get very good designs.
I think it is fair to say that stigma in many places is also rampant still in the health sector. And we really don't want to start out by blaming these health workers. Very often this is a knowledge gap. Very often this is obviously influenced by societal norms. It is influenced by legal framework that exist in these countries that also obviously reinforce some of the societal prejudices and discrimination that exists. So it is obviously not easy to always overcome those, but I think it is a real responsibility and a really important area in our quality improvement efforts to combat that, to provide opportunities for health workers to be adequately trained, to have an opportunity to understand sort of risk behaviors of some of the patients and to address them, and also to understand the specific need that some of those may have. In our key population guidelines, we have specifically formulated what we call comprehensive service packages that basically stipulate what a, let's say, injecting drug user should receive in terms of the services. There shouldn't be any dispute that these people should have access to harm reduction services such as opioid substitution therapy, needle exchange programs, etc., etc.
The absolute focus of services that you need for sex workers is different from the outreach you need for men having sex with men. It's just different from the people who inject drugs, and it's different from young women. And I think what we've tried to do, and sometimes in that one phrase, link a lot of individuals with very different needs and very different requirements for a quality of care. And I think in this last session you really heard people breaking that down and saying, no, we really need specific quality and specific outreach to different groups that meet their needs.
Very early on we realized that we can't work with doctors only. 80% of our facilities are run by nurses, and these are the facilities or clinics that are accessible to the patient closer to their homes in the rural areas. So we really had to make sure that the nurses are capacitated to provide both TB and HIV services. So we, in addition to training them, for TB initiation, like diagnostics and deciding to start TB treatment for a patient. We also train them on the decision making and the initiation, the prescription for the ARVs. However, we don't leave them alone because they get very nervous when they are on their own. So what we do is to attach clinics to facilities. So each nurse knows which doctor supports them in terms of the service provision. So they use phone calls, they call. Sometimes we use WhatsApp, take a picture of a lesion and send it to the doctor, and the doctor gives the advice.
The biggest success story, I think, has been in voluntary medical male circumcision. Everybody was very concerned about its rollout in resource-limited settings, and so each of those sites were tracked very carefully for all kinds of adverse events, as well as quality of services. The clinics were visited very frequently, and so I think we've seen real improvement at each site over time, and that's been very impressive.
I was in a very busy clinic in Kenya, and the nurses there were very, very proud of some of the work that they had done to increase the screening of patients for TB. They were very proud of the work that they'd done, and they showed me their handwritten charts. They had done flow charts on the patient flow through the clinic. They did handwritten charts on their progress where they plotted their progress on a graph for the improvements that they had made. They're very invested. They own their data. They own their results. They're very proud of their results, and they were recognized for their successes as well.
I think the other impressive area has been the establishment of the African Society for Laboratory Medicine, where it's really a continent-led response about laboratory quality, and it's really adapted for the continent, and the leadership is all African, and we're very excited about that piece of it too.
The experience we've had in HIV, if you have an important innovation and you want to see it picked up and disseminated and spread, it's very, very important to have some positive, concrete examples of where this approach has made a difference. What governments want to see, of course, is that it is cost-effective or cost-saving. Right? What clinicians want to see is that their patients do better and they get better outcomes, right? So you need that kind of evidence. What the community wants to see is that it's easier to stay on treatment, it's less burdensome, it's less stigmatizing, that it's more efficient, it's more humane, that they get treated with dignity.
When people see results that can be obtained not just from knowing the science alone, but also knowing that that science is delivered in everyday practices and steps that different people fulfill as they're delivering care, then they start to see that, okay, that I can do, that.
What I think could be very important is having the data available. Because when the data is available at the community level or at the health center level or at the district hospital, in general, healthcare workers want to do a good job. And when they can see how they're doing compared to others and the data is available to them on a routine basis so they can make mid-course corrections so it becomes a constant. We often talk about quality improvement, it's like it's a one-time thing. It's a constant, ongoing approach to healthcare.
We need to form partnerships. Definitely the government, Ministry of Health have a role to play in terms of policy formulation, in terms of mobilizing for resources and also providing the funding. But all other stakeholders, like the development partners, the patients themselves are key. You need all the stakeholders if you are to really improve.
At the moment, players are playing differently. It's like having a team, a football team with 11 players, but everyone playing his or her own style. And so when you have all the 11 players playing in the same style, talking the same language, meeting regularly, coming together saying these are the indicators that we need to follow, bringing the number of indicators to a minimum, that would be the best way to do it.
As a country, we have to come together to get a strategy. How shall we implement quality? how shall we coordinate the different stakeholders who are doing quality? How do we get the indicators we need to monitor at national level, regional level, district level, health facility level, and even at customer, client level, plus what? Community level.
We at Ministry of Health, when we do our planning, we must make sure that QI is in the center of our planning. Previously, we never used to think about it.
The positive aspect that I see is there's really a great convergence in thinking in countries, but also by the major partners, implementation partners. I hear PEPFAR talking about this, I hear Global Fund talking about this. If we all work together, I think we should be able to really increase quality and efficiency and ultimately get to where we want to be.